Cool. Well, thank you guys for joining us. How's everyone doing tonight? Yeah, great. That's good to hear. Um, I am super excited for tonight's program. We have some awesome speakers, but I just wanted to kick it off to bring up Stacy Lloyd from the AMA. She's going to give a little bit of background about AMA. They're like one of our hosts for tonight's program, and then she's going to also talk about Sling Health, which is another host for tonight's program, and talk a little bit about the objectives of what we're going to do in the next 4 programs over the next 6 months. So, Stacy?
Thanks, Priyanka. Hi everyone. My name is Stacy Lloyd. I am the senior manager in our digital health strategy team at the AMA, and a lot of our focus is really on making sure that the physician voice is integrated into healthcare technology. I think we learned a lot with electronic health records and things like that, so we're really trying to make sure that with some of these emerging technologies and digital tools that are coming into practice today, that the physician voice, inclusive of residents, medical students like yourselves, are also included in there as well. So I'll mention one specific platform that we do have. It's called the Physician Innovation Network. It's kind of like a Match.com meets LinkedIn for health tech companies and physicians to connect and really have that opportunity to bridge that kind of gap that we've seen historically in healthcare today. So, and we have a bunch of other resources and information and educational content on the site as well. So if anyone has any questions about that, definitely feel free to reach out to me following this program. Also want to give you a little bit of background on Sling Health. I'm not sure if anyone in the room has heard of Sling Health. Raise of hands. No? Awesome. Okay. Of course you guys did. It was really helpful in talking to Priyanka earlier today because I didn't realize that she had not heard of them as well, so I thought it would be really useful to share a little bit about them. They weren't able to join us today, but if you come back to one of the other sessions, you may get to meet a few of the folks that have helped bring Sling Health to what they are today. So they are a biotech incubator, if you will, out of WashU in St. Louis is where they originated, and they were started by medical students. And what they do is really help get students involved in the identification of unmet clinical needs and create teams to create solutions and products around those needs in practice. So they now have at least 10 chapters, maybe more, across the country, and they have students in both, I should say 3 medical students, engineering students, and business students that work together to help create solutions and products around locally sourced clinical problems in practice. And each year they have a demo day that they kind of report out, if you will, the prototypes and the companies that they have started based on the problems that they've identified in their local environment. So they're very dedicated to helping students get involved in entrepreneurship, help them learn about it, and if they want to move forward in creating companies, health tech companies, they kind of help facilitate that and give them a path to do that, in addition to continuing on into residency and ultimately becoming physicians as well. So again, any questions that you have about their program, absolutely happy to connect you with their team as well. At the AMA, I should also mention there's a very active medical student section. We have a program called Accelerating Medical Education, where we're helping to redefine what medical education looks like with a consortium of 32 schools, helping medical students get access to better understanding the business side of healthcare, health system science, and things like that to really better prepare you guys as students to be functioning and be successful physicians in practice as you continue to move through the process, I suppose. So we're really, really excited to be here, really excited to support this program, bigger, larger partners with Matter in general as well, but think this is a really useful series of content and education for each of you to kind of learn a new side that maybe you're not getting as much in your day-to-day education. So I think, what else did you want me to cover? Objectives. Oh, today. So the U.S. healthcare landscape is obviously today, I thought it would be a good place to start. the conversation. And then the following three series pieces of this series will include physician entrepreneurship specifically, where I think we will probably have some of the successful physicians that have started companies through the Sling Health program, in addition to some of the Matter companies as well. And then I think the third one is planned to be either design thinking in healthcare. So that will help you kind of think through how to get started. And then the fourth one is pilots in systems. And that can be useful, I think, if you end up going the route of being interested in starting your own product, and what does that look like in piloting in the health system, but also as physicians really understanding what that looks like. How do these companies come to you? What does a pilot look like? What do you need from a company? And really starting to think through what that looks like to be partnering with the future digital health companies that might come to you as physicians saying, I want you to use my product in practice. What do you think? So that will be the four series or sessions within this series. Really excited. I hope you guys return after this one, and we really look forward to your feedback for future types of educational content and programming that we can help give to you. So I'll stop there and let Priyanka take it over. Thanks again for being here, and thanks to the speakers as well.
Thank you. Yeah, thank you, Stacy. I don't know if I actually introduced myself. I'm Priyanka. I'm a program associate here at Matter. So how many of you guys have actually been at Matter? I know you have, but how many else? Yeah, okay, cool. So a lot of people have been actually here. So that's really awesome. But there are some new folks, so welcome. Please feel free to check out the space afterwards. It's really cool. So I don't know if you guys know what Matter is, but we are a health tech incubator and a corporate innovation accelerator. We started about in February of 2015, and we started with over 30 startups in our space. And we've grown tremendously since then. We have over 240 health tech startups who we work with, and over 60 industry partners that we work with. So our industry partners are our health systems, our health plans, pharmaceutical companies, med device companies, anyone that kind of has a stake in healthcare. So we work to really kind of bring together our industry partners and our startups and facilitate collaboration and innovation. We kind of group what we do in 3 different types of buckets, since it's kind of all over the place otherwise, but we are a startup incubator, so we work directly with our startups, providing them with the resources and tools that they need to grow and excel. We are a community nexus, so we provide a wide range of programming efforts that kind of bring in our industry partners and our startups and other people in our community to facilitate growth and networking and collaboration. And then we're also a corporate innovation accelerator, so we work with our industry partners pretty closely and kind of help them become more innovative. So that might be them tapping onto some of our startups, or that might be working internally with them to help them grow like kind of more of like an entrepreneurial mindset. So that's what we do. But if you have any questions, please feel free to reach out to me. I'm Priyanka at matter.health, and so I'll be happy to talk to you about Matter or anything that we can do for you. And then to talk a little bit about the goal for tonight's program, we kind of wanted to provide you some background information on the other aspects of the healthcare ecosystem. So talking through what the health system business model looks like, what the payer business model looks like, and what the med device pharmaceutical business model looks like. Kind of going through their objectives and their incentives, some of how they kind of work in relation to, like what they do in relation to the patient, and some of the industry inefficiencies that they face, and why they're interested in startups and why they're interested in other innovation efforts. So we hope this program will be valuable to you. We have some awesome speakers to give their perspective, but we also know we have an awesome group of students here, so we want to make sure it's valuable to you, so please be sure to ask questions. We have a QA portion after the last speaker, but if you have a question and you think you're going to forget it, please feel free to raise your hand. We have mics that we can give to you. Please raise your hand because we'd like to give you the mic, since we have a live stream audience, and so we want to make sure that they can actually hear the question too. But yeah, I'll let the speakers kind of formally introduce themselves, but just to give you sort of a little bit of background, we have Allison from Rush. She's going to give you that health system perspective, And then we're going to go on to Brian Lombardo from Blue Cross Blue Shield of Illinois for the payer perspective. And last but not least, Chris from Baxter for the med device pharmaceutical perspective. So, yeah, we'll start off with Allison.
Good evening, everybody, and thanks so much for having me. Thank you to all of our hosts and to Priyanka. As she said, I'm Allison. I work at Rush. I am the Director of Quality Improvement and Training in Revenue Cycle. I worked on the clinical side and then just recently moved over to Revenue Cycle. So what I'm going to talk to you about today, very briefly in 15 minutes, is all of the many questions that Priyanka sent over to me. So I'm going to try to touch on each of those, and we'll be happy to talk with you all about any questions that you may have. Okay. A little bit about myself, just so you have an understanding of who you are listening to at this point. My background, for the past 6 years, I've been focused on performance improvement. So I did that for a number of years on the clinical side, and then, as I mentioned, recently moved into revenue cycle. Prior to that, I worked in higher education, focusing on medical students such as yourselves, as well as on nursing education, PT, OT, all of that kind of good stuff. I worked for a health system in North Carolina, a little tiny rural healthcare system, where I did population health work, focusing on reducing health disparities in these rural communities. And prior to that, I did public health advocacy, so I actually did lobbying for smoke-free Oak Park, smoke-free Chicago, and then finally smoke-free Illinois, which you all enjoy today. So just so you know, the opinions that I'm going to be sharing with you today are really my own, based on my own personal experience that I've had working for different healthcare systems, and don't represent the thoughts of any of my employers per se. Okay. You guys have heard of the IOM quality aims and the triple aim? Okay. So the first question that I was asked is, what are providers trying to accomplish? So when I started jotting down some notes on this, I realized, I was like, I'm recreating the wheel. I definitely learned about this in school. Let me pull that out. I'm glad all of you all are familiar with this. I don't think since the time that I studied this in school that this has changed for providers. We are really focused on being the best providers of care that we can be. That's been consistent for everyone who I've worked for. We were always trying to be the best provider of care. Hospitals are really working to improve population health, focused extremely or increasingly on patient experience, quality, safety, as well as satisfaction, which we'll talk about a little bit, and then of course reducing cost. I will add to the list that that I think that providers are really feeling financial crunch, increasingly so, and that staying afloat financially is becoming more and more important and a key driver for providers these days. So I'm going to go through each aim and share with you in my experience how we have worked to address those aims in the hospitals that I have worked for. So the first one is improving population health, and this is the urban example here in Chicago. So Rush has something that we call our anchor mission. We've had this for a number of years. It's something that we're really, really excited about and really proud of. And basically what we're doing is we leverage our resources to build community resources on the west side of Chicago. So how do we do that? Some of the things that we do is we hire locally and we work to develop talent locally on the west side of Chicago. We buy and source locally, so any meetings that we host at Rush, we are buying food from the west side. We work really hard to try and find vendors on the west side of Chicago to actually support those communities. We went through and reviewed all of our investment portfolios, and then also leveraging our 14,000 employees to volunteer locally on the west side. And what we're really trying to do in this population initiative is to close what we call the death gap. So basically, if you live in the Loop, you will live to 85 years of age, but if you live in Garfield Park, you are going to make it to 69. And that's what our community initiatives are really pushing to improve. Okay. Another hospital that I worked at, the rural one that I mentioned, they had a huge community health and population health initiative that was really cool. A little bit of a different focus than what we see here in Chicago at Rush. Basically what this hospital did is we surveyed the community very extensively every 3 years, and then we designed health improvement and disease prevention programs around what we found the community health needs to be. So at any given time, this hospital was running 21 programs in the communities, which was really exciting. This is one of my favorite things that I did as far as work was actually working in these dental clinics, doing drug-free partnerships, working in the schools. There were a lot of resources invested in the schools as far as community gardens. We changed the state laws on lunches and vending machines, and also put school nurses in all of the schools in the county that we were working in, which was actually really, really successful in reducing pre-diabetes indicators among school-age children. So I'm going to move on because, like I said, I have a lot to cover in a short amount of time. As far as the second aim, which is experience, covering safety, quality, and satisfaction, this is something, of course, I mentioned earlier that all of the healthcare providers want to be the best provider out there. So there's a number of organizations that are currently providing awards and rankings, as you know. So these are things that health systems are actively managing right now, dedicating entire teams to reviewing these data and figuring out how we can actually move these metrics. So the good thing about it is that these indicators bring to light our opportunities. One of the challenges is that they all use different methodologies for rating you, so you are trying to balance all of these and figure out what you can actually address. It takes a lot of resources to actually move these metrics, and we do dedicate resources to this. I did add Google and Yelp on there because that's something else that we are increasingly concerned about in terms of the understanding the patient satisfaction and what they're saying out there. So we work to manage that. I do want to mention the one thing that I think that I have seen shift in the field since we originally started talking about these aims was the move from sort of a general thinking on satisfaction, like check the box, they're satisfied, we're good to go, to a move to really design patient experiences. So in Chicago, we have a really competitive market, so we are doing everything that we can to grow the patients that we are seeing. And this extends way beyond what we consider just clinical care. So this is kind of a joke, which is the lavender on the pillow. We talk about that a lot in the hospital. Are we a hotel? What are we doing here? But increasingly so, we are really focused on things that we can do to really create a wonderful patient experience from end to end. So this is, the scheduling, registration, collection, parking is a huge deal. I don't know if you guys live in Chicago. Parking is a big deal. We have to work on that. The no waiting room, how you folks are interacting with patients at the bedside. Okay. So moving into aim number 3, cost control. The first graph is one, again, you will have seen. This is, again, healthcare, or this is healthcare as a percentage of the GDP. So you know that it's consistently growing as a proportion. This may lead us to believe that hospitals are doing really well, but the second graph shows that hospitals' profitability is down. So year over year, we are seeing less in terms of our margins, which is one of the reasons that folks who are running hospitals right now are getting increasingly concerned in terms of how we're going to actually manage our budget, and we're having less and less money to put into our infrastructure, our growth, and our innovation. Okay. Some of the things that I've seen that we've been doing to control cost is really to focus on chronic disease management to drive our readmissions and our length of stays. That goes into managing the population health. Care coordination is really important for populations where we see really high readmissions and lengths of stays. We are also working to improve level of care and ensure that patients have better access to the right level of care. So, Rush fairly recently opened an urgent care center, working to make sure that we're aligning patients with their primary care providers, transitioning to e-visits, observation, and doing everything that we can really to keep folks out of the emergency room and make sure that we're not admitting them unnecessarily. And finally, something, you all possibly have run into this already, if not you will, is decision support for clinicians. So actually utilizing our EMR to guide medical decision making, you will probably hate it because you'll get pop-ups in your face telling you that you cannot do something or that you have to do something, but that's one of the tools that we have to actually change clinical behavior. Incentives in healthcare. So this one, this is this is a lot to talk about in a short period of time in one slide. I think, still I feel that the main incentive that I experience in healthcare is the moral imperative to help patients. And I think that's what keeps me in healthcare. I don't know if it's the reason you all decided to go the route of healthcare, but it's really, I feel, still the strongest driving force for what we do in the hospital setting. Second to that, certainly our payment structures. So of course we have to do what is going to bring in money for the organization. So this really drives a lot of our decision making, particularly around where we're going to grow, what services we're going to offer or not offer. Brand and reputation, as I mentioned, we have a lot of folks who are publicly judging us for things that we're doing, so that helps us as well to sort of make priorities and think about what it is we're doing. And then finally, we also actually have a lot of self-imposed incentives that we contend with. So we have employed versus private physicians. Their incentives are not aligned. Private physicians don't really care what's going on and happening with the hospital. We see that a lot. So if we try to roll out initiatives or try to standardize something, we're challenged a lot of times there. Partnership alignment can be really interesting. Providers are increasingly going out and partnering with other organizations. So we partner with labs and surgery centers. We partner with, for tech innovation, we partner with a lot of different groups. And you'll see sometimes in these cases that the incentives are not necessarily aligned. So we'll want to do something and the other people have no incentive to do that at all. And finally, this even is happening within the medical center itself. So at the departmental and leader level, you'll find people who have different goals, have different bonus structures, so that everyone is not necessarily guaranteed to be driving to the same goal, which can cause difficulties in decision making and prioritization, of course. So this, I think, is something that's really challenging, and I think is an area where there could be a lot improved in healthcare as far as making sure that incentives are better aligned. Okay. Efficiency and waste. This, we could probably have a lot of slides on this. This is my job. This is what I do all day long, is try and create more efficiency and reduce waste in the healthcare setting. So I tried to structure it a little bit based on the IOM categories. So, as far as timely, we struggle with appointment availability. We have delays, for pre-auths. We have payers that will take 2 weeks to do a pre-auth, and they want, multiple peer-to-peers, and we have providers calling in, from, other countries. They're over at a conference trying to give a talk, and they're sneaking out to get on the phone to do one of these. In my time in North Carolina, we saw private practices shutting down one after the other. They were not sustainable in these rural communities. So in terms of getting access to timely care, those are some of the things that we are contending with right now. As far as efficiency, we have endless opportunities around that, but some of the things that came to mind for me with regard to our supply chain, we have way too much inventory, stuff is expiring, we're throwing things out, that's a lot of waste. We have supplies and equipment that are not available when we need it. We have a lot of logistical challenges. We'll have a provider running across the hospital to see a patient, and that patient's not there anymore. And then finally, I think an opportunity is really getting more folks to work at the top of their license to kind of take the productivity burden off of the physician a little bit and reduce our burnout. As far as equity, I showed the slide earlier as far as the death gap. That certainly does not begin to cover the level of inequity that we're seeing in healthcare. So, obviously if we know we have an outcome that is not equitable, we know we have a process that's not equitable. So this is something that I think that the healthcare industry is going to have to continue to contend with and figure out ways that we can actually have measurable impact to improve equity. And finally, for effectiveness, the U.S. continues to lag in international ratings. So even when we are improving, which is great news, we're not improving at the rate compared to other countries that we would consider our peers. Okay. As far as innovation and opportunity, I wanted to just spend a couple of minutes talking about some of the stuff that some of this covers both of the systems that I've worked in, and some of this is specific to Rush. But just to give you an idea of some of the innovation that we are working on, e-visits is a really big thing. We did this in actually the rural setting first because we really had to, especially with all the providers shutting down. People couldn't drive 2-3 hours to go see somebody. We had to go the route of e-visits. And then when I moved back to Chicago, this was something that was being started here as well. The use of cameras is really, really interesting. We've piloted a couple of different things using cameras actually to encourage folks to exhibit hand hygiene. So I hope you guys have learned all about this and you'll be washing your hands every time you go in and out. But we actually have looked at utilizing cameras and someone actually watching the camera who will tell you, hey, excuse me, you didn't wash your hands. RFID is something that we use. We started using it on equipment because we couldn't find our pumps. We couldn't find all of this, stuff that we needed in the hospital. Everyone's running around looking for it. And then we also, when we opened one of our new clinics, we started using it for patients. So we're giving patients badges now and actually tracking them through their visit so we can time exactly how long they're in the waiting room, exactly how long they are in rooming before the provider comes in. So we're able to look at this and make sure that patients are moving through as efficiently as possible. So that's something that has been very successful. As far as data, I think this is something that we've come a long way with, but I really think that there's a huge amount of opportunity left in terms of accessibility to data, the analytics, bringing insights, and real-time decision support. We have so much data, and I just don't feel that we're leveraging it to the extent that we could be. Increasingly looking at automation, particularly in the revenue cycle, there's a lot of opportunity, and we are leveraging automation. There's some difficulty in utilizing our EMR. We have some barriers there, but we are looking at ways of getting around that, or leveraging it to the extent that we can, and then looking at introducing other technologies to help us with automation. 3D is something that we are exploring now, particularly in the realm of training. So maybe when you are training future physicians, you will be able to leverage this technology, which we are actively working on developing. So actually figuring out how we can have training experiences using 3D. So I think that will be very, very interesting and something in a couple of years if it works out. I did want to touch on wellness and burnout. We're spending a lot of resources on that. I don't know that we have a lot of tech innovation around that right now, but if folks have ideas how we can do a better job of addressing that, we do see a lot of burnout with our providers, unfortunately, and are dedicating a lot of resources to try and figure out what we can do to mitigate that. So I think that is all that I have right now. I don't know if anyone has any questions or we want to save those to the end. Okay.
Hi, good evening. I'm Brian Lombardo. I'm from Blue Cross Blue Shield of Illinois. It's a privilege to be up in front of all you all and to speak with you guys here today. I assume you all are interested in entrepreneurship and you all are interested in at least knowledgeable about the payer as part of one of those main pillars of the healthcare landscape. But I'm going to spend a little bit of time today speaking about those three burning questions, really what the payer is trying to accomplish relative to the patient, our role in the overall healthcare continuum, and then finally how we're supporting and what our interest is in startups. So it's, let me grab this. As I mentioned, I'm Brian Lombardo. I work at Blue Cross Blue Shield of Illinois. We're part of Healthcare Service Corporation. We're combined, we have the licensees for Illinois, Texas, New Mexico, Oklahoma, Montana. Those 5 states represent about 16 million members that we care for. That makes us the fourth largest healthcare provider, healthcare insurer in the United States. Unlike our other four competitors or peers, we're the only one that's owned by the members. We're a mutual legal reserve company, which means that we're not publicly traded. That's another word to say that. When sounds a little bit better. When looking at what we're trying to accomplish as far as the patient, we're looking to make it a healthier, happier patient group. That's really our goal at the end of the day, which is probably a very large and overstated goal, but it is one that we're always trying to make the member and our customers happier at the end of the day. We're also responsible from a financial perspective. We're fiduciaries for those self-funded groups, and for the fully insured groups, it's our money that we're at risk for. So we want to continue to contain cost and drive down insurance rates, but we also want to make sure healthcare is accessible. As a community-owned organization, we want to make sure that people have access to that high-quality care and that they have the ability to go and see those providers at the right time or the right place. Our overarching goal, or when it started out, insurance was really just a way to provide a financial protection. It's kind of like blackjack when you're in Vegas. You can put down that insurance in case the ace is met with a 10 or a face card. We're kind of that same way, where people originally purchased it way back in the day as a way to make sure that if something bad happens, there was coverage and there was a doctor or a hospital that would be able to see him or her. It's that same theme today that persists, but as the overall healthcare continuum has become far more complex, we too have had to make our offerings far more complex. So we've expanded our role to go beyond just being that financial backing, to be that of really ensuring that the right care is being delivered at the right time and the right place, and ideally for the right price as well. I'm going to skip ahead to what we do as far as incentives. So our role in the healthcare space, as I mentioned, is that of a payer. On the slide up above, you'll see our different flavors. And really, historically, what we've offered is a fee-for-service reimbursement, where hospital systems and providers, they go out, they do a service, and we want to make sure that everyone is rewarded or compensated justly for that service that is provided to their member. And that's really where we started out, with a fee-for-service bucket in the PPO. Unfortunately, as people realize, the incentive in the PPO fee-for-service area is to include more treatments. So it was to drive up more treatments, to do more tests, to run more labs, and it really wasn't to contain costs. As a result, what we're trying to do, and we're trying to work with the healthcare groups, as Allison, I'm sure, is very aware with Rush, we're trying to move away from those PPO contracts to those contracts that are more global risk or full risk. We start with that pay-per-performance, where we'll look at and try and decide what quality is and what outcomes are. We're one carrier. There's umpteen other carriers that do the same thing. So you can all, I guess, look forward to that. Of hopefully by the time, I should say, you're practicing, there'll be one solidified kind of nationally accepted quality metric scores, but we each define quality a different way. So we have our own sets. This is how we judge quality. This is how we reward per performance. And then it moves all the way down the line and across. We're starting to move towards that full risk in HMO, like contracts from a PPO perspective. The more mature hospital systems, we do offer those types of opportunities where they can just get a set dollar amount, and we give them the flexibility to treat their patients and to manage their patients based on that, based on the overall risk. It's certainly, there's different levels of complexity, but at the end of the day, our goal still is to make sure that the providers are being reimbursed and that the members are receiving the right care. From what we look for startups, it's really, we have a value equation, and it's similar to value equations that you'll see other places. We look at the quality. Is the product, does it deliver some quality that is higher than what's out there today? If the answer is yes, then we're interested. If the answer is no, then the cost has to be significantly different. So the quality aspect is divided by cost, so whatever the new treatment's going to cost or the new solution's going to cost, does that value drive up from what is existing today? Is it medically necessary? Is it realistic? We're very interested in partnering with startups. We're one of the larger sponsors here at Matter, and since we're in this space, we do have a number of different partners, and as a company that has 16 million members, it's obviously difficult to try new solutions out and to pilot new things, but we always are out there looking for different solutions that might bend the cost curve and might drive better results. We have membership across our 5 states. We have membership in Illinois that has certainly different experiences than those in Texas. So we have to make sure our folks in Texas have access to care. There's counties in Texas that don't even have physicians. So how do we get those people, similar to what Allison was talking about earlier in North Carolina, how do we get those people engaged into the doctor? One of our actuaries ran a number earlier that showed that after the age of 40, if you go and have a wellness exam, it results in a $356 a year drop in your cost compared to a person that doesn't have a wellness exam. So we want to get those people out and get those members engaged and have them get those wellness exams to make sure they're really getting that proper care. Because we know that we're not necessarily the medical experts. We don't claim to be the medical experts. We have teams of clinicians and doctors, but we want to get the patients and our members to those medical experts, which will be you in 4 to 10 to 15 years, however long it takes to finish residency in your fellowships. Which brings me to kind of that last bullet as far as inefficiencies in the model. Similar to Allison, I think you guys don't necessarily want to hear me talk for the next 2 to 3 days, because there's certainly a lot of inefficiencies in the healthcare model that we see from the payer side. But the biggest inefficiency we see is a combination of 2 things. It's misalignment of incentives. A lot of that has to do with decisions that are made in kind of a silo. Maybe we make a decision as a payer that we think is going to help drive down cost or drive up quality, but it's done without necessarily thinking through the complete ramifications. Or another example might be something that a provider does, or some legislation that's rolled out in DC, where perhaps some decisions happens that there's a net result afterwards that results in some opportunity for people to make money and to really exploit the healthcare industry and give it an unfortunate name. The other thing is just that lack of collaboration. We typically, as I mentioned, have a pretty poor representation amongst our customer bases. Our NPS score hovers around 0, and that's on a good day. So members don't necessarily trust us automatically, which we're working to change that by becoming more active in communities. We've built a community center on the south side. If anyone has the opportunity, feel free to stop by. But we realize that we need to work with other people to make sure that the members are more willing to listen to our recommendations and what we see in our data. Plus, the doctors are more able to act upon that information. So we might see gaps in care or opportunities to better treat a patient. And our hope is that by working with those other pillars and those other areas, we can flush out the inefficiencies in the system, avoid some of that waste. There's typically anywhere between 200 and 500 billion dollars of waste in the healthcare system today. We can flush some of that out and really make it a better overall experience. So like I said, I'm happy to take questions. I think I wanted to save a little bit of time for the panel at the end, and happy to take questions then as well.
Thank you. How's everyone doing? Hi, everyone. My name is Chris Benassi. I will kick it off with an intro. Thank you, Priyanka, for reaching out to me, and thank you, Matter, for hosting me, and glad to be a partner with Baxter. And so I'll start with an intro, and then I might kind of turn it back towards the crowd and ask what you all might be interested in, and use that to kind of tailor the presentation a little bit. Yeah, so I'll give kind of some quick background on myself. So studied neuroscience in undergrad. From there, I went to kind of the financial realm and worked for UBS, then Goldman Sachs. I was at Goldman Sachs for about 4 years and covered biopharmaceuticals and also covered health insurers and hospitals. So part of my job was to teach investors about the different spaces and about the companies in those spaces, respectively. So it included teaching individuals at hedge funds, mutual funds, pension funds, and yeah, it was an interesting role. I moved on to Baxter, and now I have a kind of split role with M&A responsibilities, so acquiring other companies, investing in smaller companies. I'm also involved in a strategy role, so it's kind of internal consulting. I've worked on everything from kind of business turnarounds. Right now I'm working in Latin America on trying to improve operations there. Then I have another role as well where I run a business in Europe with catheters and hemofilters. So a kind of a range of different responsibilities. So I'll turn it around to the crowd for a second. I just want to make sure that I touch on things that people are interested in, and I'll probably just pick at random. So individual on the far right, what would you like to learn about?
I'd like to hear more about devices and just the pathway between the idea, maybe at an institution like a university where maybe a provider has an idea but is not sure he's the right person to monetize that, and where to go from there.
All right, great. So we'll touch on innovation all the way to commercialization and
I think I'd like to learn more about once you have a product idea in mind or a product that you have, how you go about convincing both physicians as well as payers and hospitals to take up that product.
All right, so we'll call that kind of vetting and fundraising. Okay, so let's dive into this. I'll start off with a background on Baxter. So I think Baxter sells into 113 countries globally, so really, really broad distribution. You can basically find us everywhere. We have 6 different business units, so mostly medtech. We've got about $2 billion in pharmaceuticals, and those are really kind of generic hospital channel pharmaceuticals, so not the very sexy stuff. A lot of things that you'd just kind of see in a hospital or you might be using in a regimen and you might not think twice about it. Anti-infectives, different oncolytics. So a lot of the kind of basic stuff, but usually in kind of interesting formulations. So let's start at kind of a really high level. I just want to kind of lay out the ecosystem and then we can dive into it as we go along. So healthcare spend globally is about $7 trillion as of 2015. The US, in the last figure I saw, is about 3.7 trillion. In this, I believe it's about 3.5 trillion when I crunched the data. So the US is almost half of all healthcare spend. So it's pretty wild when you see this visualization of just how much it comprises. So we'll double click on this and dive into the healthcare spend in the US, because you're probably wondering, okay, how does that tie to medical products? And that's great that healthcare spend is 7 trillion, but what is a medical product? So let's dive in one layer deeper. This is the breakdown of spend by categories in the US. And you'll see, I'm going to call on someone again. Woman behind, nope, you, yes. Yeah, what are the 2 largest categories of spend here?
Hospital care and professional services.
Okay, so that's everyone in the audience. So just be aware of that when you're hearing about cost cutting, et cetera, especially in a lot of the policy waves that are coming. You're seeing that targeted a lot. And when you look at drug spend, it's usually pretty small, or you look at med device spend, it's usually pretty small. So I'll dive in a little bit more. So it's the blue portion in this chart. This cuts it out a little bit clearer, but I'll actually voice over the numbers. So the last time I kind of cut the data, pharma spend was Depending on who you ask, it was about anywhere from 10 to 20% of total healthcare spend. MedTech, I believe, is about 7% of total spend, and then diagnostics is around kind of 3 to 4%. So overall, it's a pretty small part of the pie when you think of the kind of medical products. All right, so now let's actually dive into what medical products are. You won't hear this term thrown around too much just because it's a bit of a catch-all, where it's like, okay, we know that there's hospitals, we know that there's insurers, we know there's service organizations. I guess we'll call everything else medical products and leave it at that. So I like to think of it as any of the products that are being sold into the care setting, and so I'm going to break that into 3 buckets. The first is going to be biopharmaceuticals. So I'm sure everyone's heard of biotech, everyone's heard of pharma, and usually you're not really sure how to decipher between the two. I kind of qualify those as just drugs generally, so you can think of them as chemical entities or biological entities that are administered to patients and interact with that patient's physiology, usually causing some sort of chemical or biological change within that organism's, usually people, overall physiology. So it's kind of being absorbed and interacting with the individual. Now, it breaks into a couple of buckets, as I was saying. There's the small molecule pharma, or pharmaceutical, which has been around forever. In fact, most of the original drugs that were being found were being dug up in soils all over the world, actually. So some of the pharmaceutical companies in the 80s and 90s would actually cover their employees' vacation to fly around the world, and they'd say, hey, we'll pay for your vacation to Africa, we'll pay for your vacation to Japan, and they'd say, just make sure to bring back a bag of soil. And you'd seal up the bag of soil and you'd come back to the US. So one drug by Vertex was actually based off of a molecule, or a small chemical, a small molecule drug that was at the base of Mount Fuji in Japan. So that's like one funny fact. So a lot of this was just kind of dug up, and you found it in natural settings, and it was kind of the war between different organisms and viruses in the soil. The next is kind of the next wave in the kind of pharma production cycle. You saw it in kind of the late 70s, early 80s, which was the ability to engineer biologic drugs. So we saw it originally with insulin. A company called Genentech brought it to market, I think, in '82. And so those are really proteins. So proteins are large molecule, are the large molecule drugs, and anything smaller than 90 Daltons falls into a small molecule category. Then there's another kind of bucket, which is actually the same in many different ways. It's the generic bucket. So there's generics that are small molecule generics, and they go off patent, and a bunch of manufacturers all come out with them. Then there's biogenerics, which are biological or like biotech drugs that go off patent, and those aren't always, there aren't very many on the market. I think there's like 4 or 5 in the US right now because they're so difficult to manufacture. Okay, so that's the biopharma sphere. I'll move on from there. I don't want to drag on. Next, we'll dive into medtech. I like to just provide a simple, basic, we'll call it kind of dumb definition for medtech. Anything you can touch or feel that's tangible and is used in a care setting falls into the medtech bucket. So this is going to be anything from wipes to implants to actually complex machinery. So if you think of intuitive surgical with robotics in different surgical settings, like that all falls within medtech. So the really uninteresting, boring stuff and the exciting stuff that that may be kind of, I don't know, used in something like intuitive. The last bucket is a little different. It's basically everything that's sold into the lab. So it's diagnostics and tools. And really, a lot of the diagnostics can be qualified as drugs because they interact with the patient's samples in an in vitro type manner. So they're a lot of times they're large molecule biotech type structures, but they're not used in the patient. Like you take a sample from a patient, you take it to the lab, then you run it against this, and you see what the reaction is, and you measure that reaction. So that falls into both kind of the assays, which are the tests in the diagnostic kind of realm, and then there's the actual systems that are running those tests. Does that make sense? Do all those buckets, are those clear to everyone? Any questions? Okay, cool. I'm going to skip over some of this and leave it to everyone in the crowd to kind of stop me, and we'll go back in a sec. So I'm going to try to talk about how this ties to you, the path from kind of innovation to commercialization, and then we'll step back if we have enough time. So I'm just going to kind of talk broadly about how this fits into everyone in the audience. So why is this interesting to you as physicians? Then I'll touch on the kind of entrepreneurial side next. Well, first off, all these areas that we just talked through are products and services, actually really just products that are going to be used on patients by yourself or by your staff, and so it's going to be used all around you. And so innovation in those different areas allows you to provide better care, or it may make providing care easier. There's a lot of potential benefits and kind of hindrances as well. If someone comes out with a poorly made product that doesn't fit into your workflow, you're going to be super annoyed and wish that wasn't in your workflow. So there's a range as to how it can really manifest in a physical manner and affect your day-to-day. Additionally, there's a lot of other ways as well. Like there's forms of payment. You may innovate on a product and someone may want to purchase that or license it out from you. Or you may be kind of a KOL and you may be publishing and wanting to host that research at your center. And these companies may try to pay you for actually kind of running those services, or they may want to pay you to speak about your knowledge and how their products may fit into the ecosystem, and they're probably going to want you to say something positive. So there's a lot of different ways that this can impact, from really kind of a physical manifestation, and there's kind of the monetary compensation benefit as well. And let's talk about innovation. So I was talking about this with Mohan a little bit earlier, but in most of my interactions, I probably had like 300 kind of calls or meetings with physicians over the past like 3 years at least, and in different diligence, looking at smaller venture type investments or larger M&A. And there's really kind of a small percent that are actually considering innovating and trying to figure out how to kind of improve their own day-to-day with innovations. But the ones that are kind of pushing that forward typically kind of go through a few routes. Usually you're not seeing direct licenses. You're not seeing, you're usually seeing some sort of partnership model or some way to kind of validate their ideas is kind of how I'd put it. Whether it's through a university, whether it's partnering through something like Matter, like having these incubator type relationships allows you to have a better chance of kind of commercializing your idea, because a lot of the times it's hard to convert that idea over to a business case. So just kind of going out and selling your idea because it works is usually difficult, because the investors and the companies don't have your clinical perspective. So a lot of times it's converting, okay, there's the clinical application and here's how it converts to the sales channel and commercialization. So once you kind of tap into the networks and you see what that commercialization pathway looks like, I've noticed the odds kind of improve. The clinicians that are able to successfully kind of strike out on their own have usually had some form of those experiences in the past, where they've maybe licensed out prior technologies, or they've even kind of put together their own companies with other founders in the past. And so they aren't just kind of showing up one day and saying, hey, I have an idea, you should buy it. It's, hey, I've done the work and the diligence behind this, and here's the business case. Here's people that we partnered with, and here's why you should kind of provide funding for us to, one, test the concept, and then two, move this into, try to move this to market and get approval if that kind of test of concept works. And then after that, it's commercialization. But let's, we'll jump to the kind of pharma route is probably an easy analogy. I'll jump into that first, and then I think we're running out of time, so I can probably answer more questions in Q&A. But I'll cover this quickly. So the path in pharma is usually you're trying to discover a molecule, and it's usually being discovered in a university type setting. And overall, the drugs that are actually commercialized, it's 1 in 10,000. And so You basically bring one of those molecules to a phase 1 trial, which is usually just testing safety and starting to look at what the effects might look like in a patient population. And usually that's done after animal models, et cetera. And once you've done that, the pass-through phase 1 is actually really low. I think it's sub 10%. I want to say it's about 7%. And then that moves on to phase 2 if it looks like it's safe in patients. And phase 2 is where you start to actually look at efficacy. You usually expand the trial a little bit. I mean, I'm going to really broadly generalize. You may move from 10 patients in phase 1 to 30 or 40 in phase 2, and you have 1 or 2 endpoints where you're looking at the drug's kind of activity in the patient, whether it's having any effect. The pass-through in phase 2, I want to say, is 10 to 20%, and then it moves on to phase 3, and then you might get some really large trials. Some of the cardiologic, some of the cardiac trials in like statins, for instance, cost billions of dollars and had thousands of patients. And you usually see, over the last few years, it's probably a bit old. This is kind of a 2015 statistic. The approval rate in phase 3 was around 40%. I think it's a little higher now. But basically, at each one of these gates, you're seeing the chance of approval basically reduce. And so I think, once again, this is probably going to be more of a 2015 statistic, but I think the average cost to bring a drug from market to market was, I want to say it was around $2 billion. I may be a little off there, and it was over 10 years. I was looking at a report today by an investment bank called Leerink, and they were looking at basically new chemical entities, and which is basically a new drug, and how much the pharmaceutical companies were spending to actually get that to market. I think it was 5.6 billion on average per year to bring a new drug to market. So there's incredible spending going into this. I'll quickly pivot to the medtech side, and then I think we're out of time. I'll probably see the red light for the Oscars go on. So with medtech, there's usually 2 pathways. There's a 510K pathway, which is based off precedent innovation. So if there's, I don't know, let's make this really simple. If there's an implant that was based off a prior implant model from 10 years ago, you can usually get kind of a fast-track 510K approval, and that usually gets approved within 90 days, and it's through the FDA. Next is kind of a PMA approval, and those are for the more novel type devices, and that can take as much as 18 months. So that's probably the closest to an FDA approval like you would have seen in the pharma space. So I'll stop there. I know there were kind of a lot of generalizations and a lot of kind of fast-tracked concepts, but would love to kind of turn it over for Q&A now or with the rest of the panel.
Who would pay for that is, I guess, the big question, and where would y'all fit into that? Like, insurance companies pay for that, but physician groups do that.
Yeah. So we typically don't pay for things, and it's on just that. We typically don't pay for things until they're proven. But that being said, we are interested in pilots. There are certainly are companies that I know of, including a person that sat in a chair much like you a year or two ago. He's now at Northwestern, and he launched a company called Lytic that's looking at using AI it's a symptom checker that his application is, where you put your symptoms in, it'll go through the algorithm to figure out what's the most likely thing. It'll ask you the questions much like as if you were in the ER room, and then shoot out, here's where you should go for care. We still are examining the opportunity. Babylon Health is a startup in that space that is very well established overseas in London. They're with the NHS. So there is an appetite in that space. As far as who would pay for it, probably not us to begin with. I don't know if you want to take the mic.
This is something that we have done some work in the clinical settings, just utilizing the EMR, even following through the algorithms, and then giving information and looking for basically risk factors, and saying what the propensity is of a patient to have a certain likelihood of a certain outcome, which I think is what you're talking about. I think this is something that we would definitely be interested in expanding on and providing more real-time feedback, particularly if it could be tied to actionable items and recommendations. I think that folks could do in terms of actual change. As far as the payment structures, I think it probably depends on where you are in the development. We have clinicians within hospitals who are actively innovating on this type of thing. Sometimes they're able to build it and do research on it within the medical center, and then look to sell it. So that's one model. If you want to develop it elsewhere and get seed funding and then come with a more developed model, then that would sort of be another approach.
I don't think this will answer your question, but this will be kind of just a list of complaints that I've had in looking and speaking with these companies. So there is a dearth of real life data and showing that the different technologies in the kind of AI, ML, algo, whatever buzzword you want to use, space, actually kind of drives improved results. And I'm not talking about just like one hospital. It's really easy to show results in one hospital, but across a range of different hospitals, because there's all different workflows. There's completely different care pathways in the different hospitals, and finding a actual like scalable technology across the U.S. health system is really difficult. I've seen tons of just pockets of innovation, like, oh, this works great in our hospital, fantastic, you've got 400 beds. As soon as you tried to bring it out elsewhere, it flopped. So there's kind of a big issue there in terms of like actual data sets. Then in terms of the like earlier stage stuff, I see a lot of application towards retroactive data sets and populations, and saying like, oh, we reverse engineer this algorithm based off 20,000 patients in this registry. It's like, cool, that's fantastic. Like, you can crunch the data as much as you want, and you can always dig out things that work, but you don't have anything that's kind of tangible proof that it works. Then the next big question is, okay, who's going to pay for it? So the only kind of group that I've seen paying for this right now, it has been the hospitals in certain instances where they have been able to demonstrate benefits, and where they've demonstrated benefits, the other question is like, how do you actually get paid enough that you make up your costs? Because the kind of amounts that I've seen getting paid to the hospitals is usually minimal, and so I don't know. This is just some quick math, but if you had there's over 5,000 hospitals in the U.S. Let's use 5,000 for basic math. If you paid 100 grand to each hospital, or each hospital paid you 100 grand over that first year, you'd make $500 million. And which, in the scheme of things, is peanuts. Like the largest drug, Humira, made $20 billion last year. So that assumes that you had penetration into every hospital in the U.S. and they paid you 100 grand. So those are the types of models I see, and it's really hard to find that path to commercialization. So you need data to drive the purchasing process, and without that, you're not going to get insurers to pay for it or hospitals to pay for it.
So I have a question from a quality and safety perspective. Um, I remember a couple years ago, before I was in medical school, I was talking to my personal physician, and he was explaining to me sort of what you had mentioned about the pop-ups that you get in the EMR, and we kind of talked about like the decision fatigue that can come with that, and how you want to make sure you're not missing something important, but when if there's so many, then it becomes difficult to wade through them all. So like what is kind of your approach to that, and what are some ways that you find to be particularly effective in catching inefficiencies or catching unsafe behaviors before they become really problematic?
So, I think that the way that we look at that is just balancing the risk. So if there's something that's regulatory related, if it's patient safety related, depending on, how frequently it's happening, whether we provide, these pop-ups. It's one tool that we have. It's actually a very effective tool at educating providers. So, we would leverage these, again, in these scenarios, if there was a regulatory or a safety component that we needed to enforce. There's different levels of them, so you can pop them up just for information. You can pop them up with hard stops where you cannot move forward unless you do something. So we do leverage both of those. Yes, I mean, providers will say that, providers are sick of these things. They don't like them. Anytime I think someone is prevented from moving forward in their work, but unfortunately we do have a lot of folks who are overseeing our work who, we have to meet the regulations. We have to, adhere to some of our provider guidelines so that we can get paid. And, unfortunately, that's the position that we're in right now. In terms of other things that we do, I mean, we do try to work on provider education. We, will send emails, we will have meetings, we will bring you all lunch, we do a lot of stuff. There is nothing as effective as stopping you in your tracks to get you to do something. It's the tool that we have right now. I think that, as we become more advanced, I think that we'll be able to guide paths, hopefully in a better way, in terms of the decision support, so that we don't have to go that route.
Thanks.
And just to elaborate that from our side, we envision a future too that's a lot less clicking and a lot less everything else. I mean, prior authorizations, nobody likes them. It takes a lot on our end to review them, to look at them. It takes a whole lot on the provider's end to write them in, send them in. We have a team of medical directors that their whole job is to review prior auths. But they're the unfortunate reality of what we need today to make sure that the care is being delivered at the right place and the right time. In the future, we are looking at ways to maybe gold label or establish, all right, this facility always does a good job with their care. They've proven and really looking at their claim and all the requests that come through, they'd get it, to start to take some of that burden off, or to leverage technology to capture what's already in the medical record, so that you don't have to send them back and forth. And it just allows, again, for that oversight from a quality perspective, without all the additional steps to go through. Thanks. See a hand over there. Oh, just a scratch.
Anybody?
I guess when you're talking about like the quality metrics that BCBS chooses to use, I'm curious how much you go off of things like what Medicaid and Medicare are doing, and how much do you incorporate that? How much innovation is BCBS doing in terms of, I guess, what quality metrics to use and how you decide on which ones to use?
Yeah, so there's a few kind of stalwart quality metrics out there that are generally accepted, NCQA, things like that you can just say, all right, this typically, if they go through their metrics, we'll probably want to leverage that as well. The reality is CMS typically drives the way. If they have something out there, then most are going to follow, because it's just easier that way. Everyone's already accustomed to having it in their systems. But we do differ on our own, especially in local settings. So if we realize or recognize that, we'll say down on the south side of Chicago, there's a hypersensitive diabetes problem. So we'll want to make sure that the doctors are adhering to kind of that aspect of care where they're going to have that retinal scan or the retinal eye exam every single time that the member comes in. We'll have other metrics that will be involved as well. But we try and leverage what's already out there. And we are working as part of the association. So we're the Blues together. We all kind of roll up under one association, kind of almost like the NFL, where you have the league office that oversights and provides that branding. We're working with that league office so that all 36 of our different plans can come together and figure out what quality metrics do we want to see? How do we make it more standard across the United States? So at least that way, there's that, this is quality initial blush, and then you can add other metrics on beyond that.
So you mentioned about telehealth or just e-health in general. And I guess from both the provider's perspective and the payer's perspective, like a couple questions on that. Like, is that being reimbursed right now? Is there a concern about liability? Are these things being used as diagnostic tools? Or are they actually used as therapeutic or like just triage tools?
So what we have been using it for, when I was working in a more rural setting, we actually used it for this chronic disease management. So we did, check-ins with folks with diabetes and heart disease and that kind of stuff. And we actually did, we'd actually give them, like blood pressure cuffs, like all the things, and they would actually be able to submit their data back to us, so we would be able to monitor that. So that was what we did in that setting. As far as what's going on now, we're expanding what we're doing. So, so right now, e-visits are really focused on, what you might see in an urgent care setting. So, oh, I have a sore throat, or oh, I have, something more like that. So you can actually, show, you can show an arm, you can show a small cut, you can show a rash. These are things that we're actually able to do, with an e-visit right now. Yes, I mean we are getting paid for these. I'd be interested to know your thoughts on what the future is around that. But this is an opportunity to provide more access to folks at a lower cost if we don't actually have to utilize our facilities.
Yeah, and I agree. If you look where telemedicine was 10 years ago, we viewed it almost skeptically. Then we started to partner with just maybe one telemedicine national solution that we felt comfortable saying, all right, let's roll this out. Our outlook has changed a lot, more so because, again, we realize the power of it. You can reach people, especially with behavioral health. I mean, there's a lot of stigma around behavioral health. People don't necessarily want to go in and talk to their doctor and make that first step. So we realize that telehealth is going to be that opportunity. There's shortages in certain areas to see certain types of providers. It can fill that gap. We're continuing to evolve it. I think the big next step is to make sure that the quality is there. So there's certain things you can't do. You can't do an accurate blood pressure reading. You can't do some certain pulse things. You just need to have a toolkit. So we are looking at certain solutions out there that offer these types of toolkits that can go out there. So if you think of, again, rural areas where there might be one center that they can go to, and it could be almost a telehealth center where you can access those high quality leading physicians and providers, and they'll have access to one of those self blood pressure reading cuffs that will make sure that the quality aspect of that visit will persist that might not have done so in the past. So I think as telemedicine continues to evolve, we're going to continue to evolve our stance and look towards reimbursing and possibly even driving care that direction.
Hi there. Does Blue Cross Blue Shield have any kind of collaborative program with researchers that might be interested in harnessing their databases to identify inefficiencies?
Excellent question. We typically are pretty guarded with our database, but we do. There are ways to get access to data. and to work with us. I'm just not certain necessarily off the top of my head how to do that. I know we have a data repository through the association, Blue Health Intelligence, BHI, and that's one that does offer. They actually had a challenge that they launched on their own that was going to offer the ability to come in and have access to that database, which is for all the Blue plans. So it's even more powerful than just our 16 million members, because it includes the other, 80 or 90 million.
Do we have any more questions? Cool. Well, thank you guys for coming. We really appreciate it. Thank you so much. And thanks to all of you guys also for being here. I know it's a Wednesday evening, but if you're interested in healthcare entrepreneurship, there are so many resources available in our ecosystem today, so we totally urge you to take advantage of that. There's things beyond Matter and beyond the AMA. A lot of incubators around here are providing programming similar to this. So yeah, we definitely encourage you to take advantage of all that. Our next program is going to be on January 28th. So we'll be sending out an email with all that information to you guys. So cool. Thank you.